Let's go on to number 2. Presenter is Wolfgang Jani, Chair of the Department of Obstetrics and Gynecology from the University of Ulm in Germany. He's going to discuss lifestyle intervention and effect on disease-free survival in early breast cancer patients, interim analysis from the randomized Success-C study.
Dr. Osborne, I would like to thank you and the committee for selecting this abstract for presentation. Good morning to everybody. I'm very happy to present the results of the lifestyle intervention program within the Success-C study. Now we have, as already been discussed, increasing data that obesity and low level of physical activity are associated both with a higher risk for developing cancer and also for those patients who already suffered cancer with an increased risk for recurrence and reduced survival in these patients. Now, within the Success-C study, we followed a 2x2 factorial design. The first randomization being on 2 different chemotherapy regimens. We reported the results of this at an earlier San Antonio Breast Cancer Symposium. And I will now talk about the results of the second randomization, which randomized patients with a BMI between 24 and 40 to a intensified lifestyle intervention program and a control arm. So the intensified lifestyle intervention program comprised a 2-year standardized and structured telephone and mail-based intervention program in which trained experts aimed to address behavioral and motivational issues related to weight management, and this was done by 19 telephone contacts and accompanied by a detailed workbook within these patients. The control arm consisted of a general recommendations for health at the beginning of the program, at the end of the program, and a lifestyle magazine. Out of the 3,600 patients who participated in the Success-C trial, 2,292 qualified for the lifestyle intervention randomization based on their BMI between 24 and 40, 1,146 patients in each arm. Now to the results, patients who were randomized into the intensified lifestyle program lost an average of 1 kilogram, 2 pounds within the 2-year program, while patients in the non-LI arm gained almost 1 kilogram during the 2-year program. The intention to treat analysis failed to show any difference in disease-free and overall survival, both in univariate and multivariate analysis. However, we had to notice that only 64% of the patients actually completed the lifestyle program, and only less than 50% of the patients in the intensified lifestyle intervention program actually completed the final telephone contact. So we were interested in an exploratory unplanned analysis to look at patients only who completed the lifestyle program. I'll show you the results of this exploratory analysis now. Looking at weight again, we could not reproduce the difference between the 2 randomization arms in terms of weight loss among those patients who did not complete the program. However, as you can see on the right-hand side, the weight loss was much higher in those patients who actually completed the program, and the difference between the 2 arms now is 3.5 kilograms, equaling about 7 pounds. In this unplanned exploratory analysis, comparing completers and non-completers, we saw a significant survival benefit in terms of disease-free and overall survival, both in univariate and also in adjusted multivariate analysis. Now, looking at the 2 arms among completers only, and obviously these are 2 patient groups who are not of the same size anymore because of the different magnitudes of adherence, We also saw a significant advantage in terms of disease-free survival in favor of the intensified lifestyle intervention arm, both in univariate and multivariate analysis. Obviously, the study has some limitations, and the results should be interpreted with caution. We were negatively surprised that the adherence to the intensified lifestyle program, which was much lower than anticipated by ourselves. The exploratory and non-planned interim analysis, completers versus non-completers, might have some bias which might account for the survival benefit. Patients in the non-LI arm may be less well documented as they had less contacts with their physicians. And we still have a relatively low number of events in this first interim analysis. Maybe the main potential bias might be unaccounted for. Do we see a healthy participant effect in that exploratory analysis comparing completers versus non-completers? That is it only healthy patients who actually are able to complete the lifestyle intervention program? So in summary, our trial was successful in demonstrating that a telephone-based intensified lifestyle intervention program can lead to a significant weight loss of 2 pounds, while patients in the control group with general lifestyle recommendations only gained an average of about 2 pounds. Our intention to treat analysis failed to show any significant difference in disease-free and overall survival between patients in the two arms. In an exploratory analysis, patients that completed the 2-year lifestyle program encountered a higher weight loss of now about 7 pound difference and had a significantly better disease-free and overall survival compared to non-completers. The analysis among completers between the two arms also showed a significantly better disease-free survival in those patients who actually completed the intensified lifestyle program. We cannot rule out a significant bias in this exploratory analysis for the reasons mentioned. So I conclude that this analysis indicates that the completion of a systematic telephone-based lifestyle intervention program does positively impact body mass index. It's been shown in previous studies and also in a study which was presented by Dr. Goodwin here at this San Antonio Breast Cancer Symposium, and that it may improve outcome in overweight patients with early breast cancer. However, based on potential bias between completers and non-completers, the results of this analysis should be interpreted with appropriate caution. Our plan is to further analyze our study with longer follow-up and more events, look for additional outcomes like cardiovascular disease and other outcomes, and also predictive markers to find out which were the patients who actually adhered to the program and those patients who were not able to complete the program. And of course, everybody here is waiting for the large American trial, which follows a very similar regimen like we did, which is still ongoing. Thank you very much for your attention.
Okay, this abstract is open for questions. I could start by saying it's hard to imagine that a 2-pound weight loss would impact survival, but you don't always have to lose weight. Physical activity itself can be valuable. And can you discuss what the physical activity was as a part of this intervention?
Yeah, thank you very much for this question. Yes, this was the main difference to the Canadian study, where the main goal was losing body weight. For us, we wanted to do a combined lifestyle intervention, aiming at weight loss and increasing physical activity. So that was evenly part of the telephone contacts to talk to patients about how they can live with healthy diet and control their body weight, but also how to increase physical activity. And of course, as you kind of mentioned, these two come together. All the patients got a step monitor to see how many steps they did per day. And obviously, during the 19 telephone-based interviews, They got a coaching how to increase physical activity in daily life and look for possibilities individually, since there were individual, a structured individual coaching program, what would be the possibility on an individual basis to increase physical activity.
I think it's important to understand, too, that the physical activity we're talking about in these studies doesn't have to be running a marathon. You could be walking 30 minutes a day, and that's actually been shown to improve outcomes. So, but you'd be surprised at how little activity patients undergo after the diagnosis, partly related to their families telling them, oh, you need to rest because you're on this chemotherapy. Wrong recommendation, totally wrong recommendation. You need to be as active as you can. You tolerate it better, and you have better outcome.
Thank you.
I was interested in your, Alice Goodman with the ASCO Post, I'm sorry. I was interested that only 50% of patients completed it, and I think Dr. Thune had a much higher adherence rate. Do you think that's because of the face-to-face contact with the doctor that was in her study? I think that's very important when your doctor, your powerful doctor, looks at you and says, this will really help you, this will really make you feel better. So maybe the telephone is a distancer.
Oh, absolutely. I totally agree. Personal contact in many ways, of course, is very important. This is why we do it here and not just web-based. Yes, this is true. When we set up the trial, however, we thought of how can we do this in a structured way. And it just would not be feasible, at least in a country like Germany, to do that kind of study with personal context, because too much traveling, too much costs, and so on. So what you're pointing at is very important, the personal contact between physicians, nurses, and the patients. However, to do a study like this, to have a structured program, a telephone-based or now maybe even IT-based way to do it, I think is the only feasible way. And it's also a quality-controlled way, because all the persons sitting at the telephone were trained experts. So the quality of the telephone intervention was very homogeneous from the beginning of the study to the end of the study and among all different patients. And that would be much more heterogeneous if we had done it with face-to-face contacts.
Yes.
Ed Sussman with MedPage Today. Should physical exercise be part of clinical trials of new drug treatments and things like that? Should that be included as part of the protocol?
You're looking at Dr. Osborne, and I think he would be the perfect senior person to ask that. I suspect that his answer might be yes if possible. At least my answer is yes if possible. But to tell you, to implement this lifestyle intervention program within a chemotherapy study has been a huge effort. Like also the previous talk, it was a huge effort. We had experts from nutrition and medicine from Munich University who set up the program with us. We had to generate huge funds to do the program. And obviously, the sponsors you saw in my first slide were not that much interested in the program as they were in the chemotherapy objective. For us, it was very important to not only look at chemotherapy effects, but also to look at lifestyle intervention effects. But I can tell you it's been a tough effort.
Yeah, the problem with, you mentioned new drugs. Patients on new drugs, phase 1 or early phase 2 trials, are often affected a lot by the cancer itself at that stage. They have metastatic cancer, they're feeling poorly. Still, though, I think that encouraging exercise by their physician would be a smart thing to do, as much as they can do. Many of them have pain at that stage, and they're not in good shape at all. But it would still be of value, I think, if we could get them to be more active.
Thank you.
One thing that might be useful to build into these clinical studies that look at lifestyle is to add in a support component. Because we know that one reason why Weight Watchers, for example, is effective is because they have a community of people that give each other peer support and share with each other, and share. Basically, in this setting would be, let's say, a virtual, a therapeutic community that's moderated, where the individuals in the study could be invited to be part of this community and through patient-reported outcomes basically share with each other that which is useful to them, provide encouragement when and their willpower is not quite as good, and that could be part of the observed data through the length of the study to see how does a therapeutic community in companionship with the study provide to help people achieve the goal and adhere and stick with the protocol, because one of the problems here was the adherence compliance with the protocol was low.
Oh.
So maybe that would help improve that.
Absolutely, I totally agree. And that's part of what I mentioned with the predictive factors. We have diaries of all the patients, which we still have to analyze. And same thing, personal contact might be important with nurses and doctors, but also among patients. So that could be a important motivational factors. This could not be structured for obvious reasons, but we have the data in the diaries where at what magnitude the patient were within patient groups, and we're very, very curious to see the influence of that on the adherence to the program. Yes, thank you.
Thank you, Dr. Yanni.